We are starting now. Our IC is keratoconus and keratectasia, etiology, diagnosis and management strategies. And I am S. Bharti, and I have my co-instructors, Dr. Bhupesh Singh and Dr. Purendra Bhasin. Will be taking the course on this keratoconus, and I'll be talking on interpretation of corneal topography and tomography. अभी तो sign किया नहीं, कर देगा. Before I leave, I'll get it signed and give it to you. So I'll keep it there. So we'll be talking about interpretation of corneal topography and tomography, and that will form the diagnostic criteria also of the keratoconus. And then the treatment, the first line of treatment will be corneal collagen cross-linking. And then Dr. Purendra Bhasin will talk about phakic IOL in keratoconus. You have heard phakic IOL in all of the situations. We'll be talking on phakic IOLs in keratoconus. After that, Dr. Bhupesh Singh will be talking about intracorneal rings, the intacts and other corneal rings to manage the ectasia and keratoconus in such cases. And then keratoplasty techniques in ectatic diseases, that will also be taken by Dr. Bhupesh Singh. So it will be like this. And so now I'll start the course. I'll be talking on corneal collagen. The first thing is corneal topography and tomography. I'll just start that. So basically, we'll be talking about corneal topography in relation to the diagnosis of keratoconus and tomography in relation to the keratoconus diagnosis. Basically, and to stage the. Can someone close the door because there's so much of noise, please, and this one also. Thank you. So as you can see, the topography is basically what we see like from the aerial view sitting in the aircraft. We can see the elevations and troughs in the earth. Like that is what is topography is, the areas which are above the sea level and the earth, and then the below the level, and that is what is topography, as to find out where the elevation is there and wherever there is a depression. So there is a simple map which is called axial curvature, which shows the simply the steep K and the flat K and the astigmatism, and also as to what kind of eccentricity we are looking at in this topography, and along with that the shape factor, diameter of the pupil, and all such information about the cornea. And this is what is called topography in view of whatever is you are seeing on the surface of the cornea. And that is what is going to give you an information regarding the surface. So the initially what we started measuring the corneal curvature and such things was with the keratometer, and you can see the three types of keratometer, the two types of keratometer which were there earlier, almost 25 to 30 years ago. And the advantages of these things are that they were easy and they were very cheap. Simple convex mirror would catch the corneal topography, and but the problem with that was that it was only a 3 millimeter ring and 4 data points. So this 4 data points only there was so much of areas which are not measured but extrapolated. So that the only 4 points were measured, and then there was a map formed because of extrapolation of this extension of these parameters, and they assumed those paraxial optics and alignment of the corneal apex, visual axis, and this was more operator dependent because the operator was instrumental in getting these things centered properly, and indices may differ between the instruments. So then second thing which came into being was keratoscopy, which was first described by Cune, and then Henry Good he started doing keratoscopy, and then Placido, which became the most popular design to form the topography of the cornea, the Placido disc. And also through the center of that Placido disc we could take a picture and see what kind of irregularity we were looking at with the Placido disc, which actually projected 6 rings on the cornea, alternating white and black rings, and there was a possibility of seeing the vertical meridian, horizontal meridian, and the inferior steepening, and you could see that there was some areas which were not falling right in the center in the circular. So advantage was that it was very simple, handy, low cost and quick, but disadvantage was again the quality was very not fantastic. It was subjective. The central cornea was again missed because central cornea was the area where it was taking the picture from, and there was no record. You could only make a record of what you were seeing, but no such record as to what kind of picture you were getting, and the minor irregularities were missed totally completely. And because it was a gross picture of the rings which were formed on the cornea, still we use Placido's disc or something with similar to that for measuring the corneal astigmatism during cataract surgery and see whether the astigmatism is properly compensated or not. So the finally, what came into being was the Gullstrand started doing quantitative analysis of the captured image, and he created algorithms to obtain data on slope from the Placido disc image. And then this was called video keratoscopy, and this is what took us from a simple keratometry to a scopy where we could measure the anterior curvature of the cornea perfectly. The shortcoming is again data from the peripheral cornea were unreliable because this was only measuring central 6 millimeter. Elevation data were derived but not true, and this assumed fixed geometrical pattern and was not able to diagnose the irregular corneas, and inability to image the posterior surface of cornea was the biggest shortcoming, because ultimately we came to know and understand that posterior curvature of the cornea is the most important thing which goes wrong or irregular in cases where there is a corneal disease, and that is where the Placido disc and all the measurements which were taking into consideration only the anterior surface of the cornea failed to give us a proper information. And basically the other thing was that in all these devices there was a prerequisite of a healthy ocular surface. If the ocular surface was not healthy, it was irregular, it was a dry eye or something, then probably all the measurements were not correct, and we were still in the dark as to what is happening to the eye. So current topographers are two types of topographers are there, the projection based and the elevation based. And projection based are like Atlas 9000 topography, Tomy or Keratron or Astramax. And the elevation topography describes the true shape of the cornea and is most affected following keratorefractive procedures. And this elevation topography is basically what we are doing now. The slit scan topography, which were the earlier topographers like OpScan 1 and 2, And then the Scheimpflug imaging system came, which is the most gold standard as of now, like Pentacam and Galilei, and high resolution AIOCT with like Visante, which are there to give us the topography of the cornea in a better perspective. Now another thing was that we created a color scale. So the low or negative or posterior or flat or areas with a lower power or a flatter power were shown in blue colors. The green blue like water or sea, and the basic surface, which was like earth, is a flat surface like reference surface. This is the average curvature and average thickness is shown in green, and those areas which were high or positive or anterior or elevated or steep or having a higher powers in the cornea are or thin in the thinner corneas were shown in the red. So this is a simple topography which I started with, the topography of the earth, where the high areas or the mountains were shown in the red and flatter areas with green like a jungle, and then sea was seen in the blue color. And the most practiced scale was the Kleist. Stephen Kleist made this scale, which was from 28 to 65 and a half diopters, and was 1.5 diopter of equal step intervals, and this could identify all the topographic characteristics identified by more sensitive 1 diopter scale. And this was in practice for a very, very long time. Even now sometimes you still refer to Stephen Kleist scale. So maps are now curvature, elevation, and pachymetry maps. And curvature maps were generated from the curvature data like Placido disk. They are various types like axial, tangential, and mean, and represented using color-coded scales. And same data can be represented in different forms. Comparison between axial map and tangential map. This is a very important thing. Axial map assumes center along the optical axis. The tangential map does not assume it, as it has center, which is actually not optical axis. It could be center of the cornea, which could be more steep or wherever the center is. Axial map gives a global view of corneal curvature. Tangential map is a local curvature of each point in meridional directions relative to other points in a ring. So tangential map takes all the global view of the local curvature. It does not take the global view. It takes all the local curvatures in the and relation to the adjacent points. Axial map ignores all minor variations on the corneal surface. Tangential map is high degree of variability from point to point, and axial map is less. It shows less irregularity. In the tangential map, you see the irregularity is more pronounced, and you can appreciate the even if there is the smallest of change, that is shown and depicted in the tangential map in a manner which is more shown to the observer, as compared to the two machines where the most commonly used machines were OpScan and now Pentacam. And when we are comparing OpScan 2 to Pentacam, OpScan 2 is a machine which is now nearly obsolete. It is not so accurate, and also it is not so accurate in accuracy in imaging the posterior surface of the cornea, and it is not inaccurate in thin corneas, and is not a gold standard as of now, versus Pentacam, which is accurate in imaging anterior surface, posterior surface, thin cornea, or whatever type of cornea you look at. Pentacam is the gold standard and gives you, and the maps are very standardized, and reproducible. So if there is a change in the pentacam readings, they are reproducible. They are all showing the same changes every time. Is a rotating Scheimpflug camera which measures Scheimpflug images of the anterior segment and includes information from the anterior corneal surface to the posterior crystalline capsule. So it gives you a complete holistic view of the cornea and anterior chamber and the lens. And the time taken is very, very short. It is about 2 seconds or less, and there are 25,000 measured points and analyzed true elevation points with pentacam, which gives you a very fantastic information regarding the map. Now, reading the map, the sequence of reading the map is look at the anterior elevation first. The most important thing is look at the anterior elevation and then look at the posterior elevation and see the relationship between the anterior and posterior elevation, and then look at the pachymetry and thickness distribution. So there is a standard thickness distribution map which is there in the pentacam, the display, and if there is a thickness distribution is not in the within the lines which are there, then probably you have to be very cautious on seeing whether this is a normal cornea or not. And off-center distribution of corneal thickness is highly suspicious. Look at the symmetry of both the eyes. If one eye is abnormal, mostly second eye will also be having a little bit of abnormality in the beginning or whatever, because both eyes are going into the similar direction. So there is no possibility of having a one eye abnormality unless there is a reason like a trauma or other things which can cause abnormality uniocularly. And look at the curvature last, because curvature is not the very significant factor. It is significant, but when you're coming from the beginning, it is elevation and then the curvature at the bottom. So these are normal astigmatic cornea. You can see that there is these are the areas where there is a steep, and these are the areas which are flat, and you can see that there is a symmetrical bow tie here, and this is a normal astigmatic cornea. So, okay. And this is again this is suspicious keratoconus because there is steepness in the central area, which are, these areas are steeper, and that is why these areas, this could be because of the corneal warpage, it could be because of the contact lens wear, it could be because of so many factors, dry eyes. But if everything is normal, the patient has not used any such thing, then you have to be suspicious when you look at this picture where there is a suspicious elevation, steepness in the center. And this is showing the conic cornea where there is a cone location which is inferior or in the side, not from the apex, it is slightly away from apex, and this is where you go ahead and diagnose something like conus or a PMD or such things. This is a borderline cornea map of keratoconus where it could be, you have to follow it for a long time to see whether this progresses or not. This is very early keratoconus, and you have to see whether the quality of vision is deteriorating in these eyes or not. And it could be a form first kind of situation. One has to follow and see whether these are the areas, these are the maps where you are suspicious, and you need to follow these patients up every 6 months for a long time. And this is a typical case of keratoconus where there is a steepness of cornea where it's the front elevation is 30 plus 30 more than the area which is flatter, and it is the flatter area is about minus 24. So the difference is very high, and the back, if you look at the back surface, the difference is even more pronounced, and this is a typical case of keratoconus where there is a steepening and flattening on the other axis, and this is a diagnostic of the conus. So in the pachymetry, the most important points are displayed in values: thickness in the pupillary center, thickness in the apex, and thinnest location. And preoperative, this is very important. Preoperative planning of the corneal refractive surgery for glaucoma screening, and also for IOP modification with regard to corneal thickness and keratoconus detection and quantification. You can diagnose keratoconus accordingly. And if this corneal thickness is 440 here and goes up to 660, so you have to see what kind of corneal thickness distribution we are looking at, and if that thickness is falling within the range, then otherwise it is in the center of the cone, then it is different, and then it has to be measured as to what kind of relationship to the apex of the cornea we are looking at. So there is a corneal thickness spatial profile, or corneal thickness values at the TP is determined, and averages of thickness values of points within 22 imaginary circles centered on the TP with increased diameter at 0.4 millimeter steps are calculated to create the corneal thickness spatial profile like this. And this is an indicator, or this is a very good measure of the corneal thickness increment towards the periphery, and gives you an idea as to whether this patient is having a conus or not. And percentage of increase in thickness can be calculated for each position using the simple formula: is thinnest corneal mean corneal thickness in the ring and thinnest corneal thickness divided by thinnest corneal thickness. So this is which gives you an idea whether you have a conus or not in these cases. And the post-LASIK ectasia, the pachymetric progression is abrupt in both the eyes, because the center of the cornea is being already ablated with the laser. So that is why there is a significant indication of ectasia in all these cases, which are very well documented and easy to define. And this is a normal thin cornea, where the progression of the corneal thickness is falling between these lines, and this is all within the normal. The thinnest is 499, the apex is 503, and pupil center is 502. So these, if you look at these measurements, they are actually within a very short this thing, and they can be taken as normal. These are all normal readings of the corneal pachymetry map. And an ectatic cornea, the thinnest local is 300 and whatever, 90 or 98, and apex is 420, and pupil center is 405. So you can see that this graph is falling much below the range which is shown as normal, and that is why this is a case of ectasia in these cases. And these are the cone areas which you can observe and appreciate. So this is another this is a Fuchs dystrophy, where you see there is corneal thickness is increasing because of the Fuchs dystrophy and the endothelial cell deficiency. And because of that, there is this thickness increases in the periphery much more than actually what is actually normally seen. So the red line is falling beyond the black lines which are there within the normal range. And this is a thick cornea with abnormal corneal thickness progression, but still within the normal limits. Little bit of it is going away, but still falling within these three lines. So this is fine, and it is not actually a diseased cornea in these cases. Now another thing which is important is enhanced ectasia display. And the original display, the Bellin-Ambrosio enhanced dictator display software showed both anterior and posterior elevation data relative to a standard best fit sphere calculated at a fixed optical zone of 8 mm. The second component of Bellin-Ambrosio enhanced dictator displays is a comprehensive pachymetric evaluation, and average progression index is 0.5, less than 1.2 is a normal, and more than 1.2, if there is a progression index is more than 1.2, it is ectasia. The shape of the curve, the thickness profile, and percentage of thickness increase gives additional information. Flat curve may be a normal cornea, but watch out for endothelial disease like Fuchs or Gutte. And steep curve could be ectasia or ectatic susceptibility. Flattening in the periphery only is ocular hypertension. So the new display report 5 different parameters individually: change in the anterior elevation from standard to enhanced, change in the posterior elevation, corneal thickness at the apex, the TP displacement, and pachymetry progression. And this gives you an idea as to what is the elevation. The bad 2 is the values shown in the bottom right of the display and is reported in numerical form, giving the standard deviation from the population meant for mean for individual parameter. These are color coded to turn yellow when they are more than 1.6 of standard deviation, and anything more than 2.6 is red. So when these parameters are in yellow, they are in the they are, they make you aware of the fact, and you are conscious of the fact that the yellow marker there. But when it is red, it is really not correct. The final parameter D represents an overall reading of all 5 parameters. This is calculated by performing a regression analysis against a standard database of normal and keratoconic cornea. So these, you can see here it is not shown, but let's see. Yes, so this is anything more than 1.6 is yellow, and whenever, and you have to be cautious about this thing, whether this is normal or not. Maybe you have to do a pentacam reading once again after a few days, or once the patient is taken, treated with lubricants, or otherwise also you have to follow it up whether this is going wrong or not. But when these readings are read, that means this is a case of um, uh, this increased D value, where all the other parameters are red, but this D value is more than 3.23. So that is why this is, even in the front curvature and back curvature, both of there is these yellow spots are there. So you can see that these are not normal corneas, and they have got ectasia or ectatic possibility of ectasia in all these cases. And this is again important. The anterior surface is normal, but posterior curvature is showing plus 15 change in the curvature in the center. So this is where this dB is 2.27, and this is because of the isolated suspicious area in the posterior cornea, and one has to follow it up before taking this case up for the refractive surgery. So this interpretation should always be in conjunction with clinical scenario, and try not to misinterpret the colors, because colors could be, when you are taking a scale, that scale, what kind of scale you are, what kind of colors you have given to a certain values, that also shows the colors. So the more important thing is not to look at the colors, but at the readings which are there. Thank you. So I'll be talking about the corneal collagen cross-linking as well on the same continuation. And corneal collagen cross-linking seems to be the best bet for the treatment of corneal ectasia, primary or secondary, whatever kind of ectasia we're looking at, we have to see. And this is the original method of therapeutic corneal cross-linking was developed in Germany in 1998. The Dresden Protocol involves the use of UVA light and riboflavin to form bonds between collagen. And although the exact mechanism is unknown, it is believed that riboflavin causes the release of oxygen radicals that in turn induces an oxidation to create new cross-linking bonds and makes the cornea more stiff and not, amenable to any more ectasia after that. So the mechanism is riboflavin activated by UVA, reaches the active triplet stage, releases free radicals or oxygen reactive species to surrounding stroma, and this causes hydrogen bond or cross-linking among amino acids in collagen fibers in intra and interhelical levels and intermicrofibrillar level, and this causes the stiffening of the cornea. And this has to be done after the epithelial debridement. And riboflavin, depending upon what kind of riboflavin you want to use, 0.1% or 0.2%, and 3 milliwatt for 30 minutes of UVA radiation. Now we have come to a situation we use 9 milliwatt for 10 minutes instead of 3 milliwatt for 30 minutes, because now we are doing a accelerated cross-linking. And on keratocytes, riboflavin alone has no cytotoxic effect on keratocytes, but UVA alone has necrotic effect of the cornea. But when they are combined, they become safer. The cytotoxic threshold of inducing cellular necrosis is 5 milliwatt per square centimeter for UVA light alone, and 5 milliwatt for per square centimeter for UVA plus riboflavin treatment. So 0.5 milliwatt, sorry. So the requirement of ultraviolet light to induce necrosis of keratocytes is highly increased and sensitized, and even a smallest of UVA light damages. And but this treatment is safe, and corneas that have been adequately saturated with riboflavin are at least 400 micron in thickness. The goal of corneal collagen cross-linking is to stop the progression of the disease, thereby stabilizing the corneal ectasia. And the procedure is simple. It is topical anesthesia, manual deepithelization, or laser deepithelization. Riboflavin every 3 minutes for 30 minutes. Clear fluorescence is to be observed within the antechamber seen by slit lamp with the blue light. Irradiate the cornea for 30 minutes with UVA. Drop riboflavin during this irradiation. Also continue dropping our riboflavin every 5 minutes, and apply 2 minutes every 2 minutes BSS to keep the corneal thickness same, because if you let the cornea dry, the thickness of the cornea reduces, and the effect of the can go up to deeper tissues, and treatment has to be visually controlled. This is how we position the patient. It has to be practically totally horizontal, and as you can see, the preoperative, the keratocyte, they degenerate and then again regenerate in 6 months time. So this is the initial degeneration of the keratocytes which happens, and then they regenerate to become a normal cornea. And the keratocytes are killed 300 micron deep, and repopulation takes 6 months. Accelerated cross-linking is like 3 milliwatt into 30 is 90 milliwatt. So 30 minutes exposure time is uncomfortable. So what you use is 9 milliwatt for 10 minutes. So you can use 10 milliwatt for 9 minutes or something like that, or maybe 18 milliwatt for 5 minutes is okay. And but 30 milliwatt into 3 minutes is equivalent to again 90 milliwatt exposure, but it causes so much of keratocyte damage that it does not regenerate properly. For thin corneas, you can use hypotonic cross-linking or transepithelial cross-linking, because if you remove the epithelium, the cornea becomes thinner, and then it can go beyond 300 microns and reach up to endothelium. The contact lens assisted cross-linking or smile lenticule assisted cross-linking, where you put smile lenticule or a contact lens impregnated with riboflavin on the surface of the cornea and then expose, so that the penetration of the ultraviolet light is not going up to the endothelium and it is remaining within the stroma, so that there is no damage to endothelium because of the ultraviolet, because that is irreversible kind of damage. Okay, so I have to attach the charger, otherwise this will shut off. कोई बात नहीं, बाहर से लगा दो, इसको लगा दो बस. Go forward. For a hypotonic, we can use it in about 320 micron cornea, and transepithelial is not very. I would not suggest. Efficacy is not much. It is only 25% efficacious as compared to normal cross-linking, and epithelial removal is necessary. And a study used immunofluorescence to conclude that for diffusion of riboflavin throughout the corneal stroma, the epithelium should be removed as an important initial step in the treatment. Contact lens assisted cross-linking, I have already discussed that. When the corneas do not swell enough to make hypoosmolar cross-linking possible, contact lens assisted cross-linking can be done. And the thickness of the cornea is artificially increased by increasing amount of riboflavin containing substance entered to the stroma, and this is where the impregnated contact lens is put on the cornea, and then it can be, after that it can be exposed to the ultraviolet. And combined cross-linking with Intacs, we can take it at a